Hearing me well enough? Okay.
Yes, thank you. And I am Sue Atkine, for those of you who don't know me, from Eastman Cares. This is a presentation of the Eastman Cares Education Subcommittee. And my wonderful team, some of whom are on this, I thank them for their help. A couple announcements that I always make before we start is a reminder to people that Eastman Cares does put out a resource guide. We update it every year. It's available both online at the Eastman Cares website, as well as you can just go down to South Cove and pick up a copy. It's really a very useful document in terms of whether you're new here or not, really, in terms of what the resources are that are available. The other thing that I always want to talk about is that Eastman Cares now has a Eastman Cares connection established, so that if there's anyone, including yourself or anyone you know, who thinks could benefit from having someone to talk to, whether that someone is, needs someone on a daily basis, a weekly basis, a monthly, whatever the needs are. We do have people who have volunteered from the committee to be available to anybody who needs it. All you have to do is go on the Eastman Cares at eastmanh.org, and someone will get back to you and we'll figure out what we can do. So that's a really good resource, and not just if you're living alone either. So please, if you need that, we would appreciate it. As I said, these webinars are set up just as a webinar so that you will not, participants won't be seen, and you will not have an audio either. However, that being said, we really strongly do encourage questions and answers. We will stop about halfway through the talk to see what questions have come up. And then, of course, there'll be ample time at the end. We ask just because it's easier for us, that you put your Q&A in the Q&A, which is at the bottom, for most people, at the bottom of your screen. And we will, as I said, Paul will be monitoring those. So we encourage that. Let's see. Evaluations, as you know, people who have attended these when we actually had them in person, we always did an evaluation. It's a little more difficult in this regard, but we do really appreciate any comments about presentations, any suggestions about potential topics for the future. We would really encourage. We are recording this, and the recording of this talk will be on the Eastman website, Eastman Cares at eastmanh.org. There's a new link, I have to say. The link that I provided, actually for the last two, turns out expired. So I do have a new link for all of them, which we'll be posting both on the announcements and in Eastman highlights. So you will be able to see this. Let's see, and then I have to talk about our next talk, which is on March 11th. And on March 11th, we'll be doing, do you know what steps to take if there's a death in the family? Might seem like it's pretty easy, but it's actually not all that easy. And when you're in the middle of a crisis like that, it's really good to have some sort of resources available. So the Chadwick Funeral Home is going to do that for us. And so you'll get a notice about that. That's the next one. Now, finally, this one, I'm really pleased to welcome Roger Osmun and Bill Metcalfe. They're from West Central Behavioral Health. They were actually recommended to us by Ken Dolkart, and I'm very happy that he did, because as you may have seen from the West Central's monthly newsletters, if you get those, the Grantham listserv, Facebook, email, whatever, this is the Community Behavioral Health Center that serves our particular area. That's all of Sullivan County and Lower Grafton County. It's one of 10 behavioral health centers. They're probably going to say some of this, but that's okay. Behavioral health center statewide is a private nonprofit serving our community. Many of about 85% of the clients are Medicaid or Medicaid eligible. So they really do serve some of the most vulnerable among us. I think it's very exciting that they are about to tell us about something brand new. 6 weeks, I think, is what Roger told me, is that's all it's been so far. And they're going to tell us about the rapid response access point and a little bit about what's happening in other places. I did want to say, though, there's been a couple articles actually recently in the paper some of you may have seen. And one of them was about a trip to Canaan, which Roger, I think Dave did that one, yep. But a member of the West Central Behavioral Health went to Canaan, and it talks about what great community support they had there, and which I think is extremely important, and is one of the reasons why I wanted us as a community to hear about this. And they also just had a rapid response article in the Valley News as well, talking about their services. So it's exciting that they're getting some attention. A little bit about our two speakers. Roger received his doctorate in clinical psychology from Temple. He's been an administrator in community mental health for the past 26 years. He moved to New Hampshire in 2019. Welcome. And became the CEO of West Central Behavioral Health. He previously had a small private practice and was on the graduate level faculty at Immaculata University for 20 years, I guess. His clinical work has emphasized child, adolescent, and family health, in addition to neuropsychological assessment. He oversaw actually mobile crisis units in 2 counties in the immediate suburbs right around Philadelphia. And he did that for 2 decades, and now he's here to try to implement the first of the kind in New Hampshire. So we welcome Roger, and I'm going to introduce Bill as well. Oops. I have the right piece of paper here. Okay, Bill received his Master of Social Work from Springfield College, which is right near actually where I grew up, in Springfield, Mass. He received his New Hampshire license for social work in 2019. He's worked for West Central for 6 years, first as a clinician and then as a crisis director in 2019. Previously, he worked for healthcare and rehab services in Springfield, Vermont, this time, for 14 years. And he's worked for 20 plus years with individuals with intellectual disability and then 12 years with individuals with mental health. So clearly we have quite the experts with us today, and we're very happy to welcome them. And with all that said, welcome.
Thank you. We're happy to be here today. I'm glad you were able to invite us and we could be part of your group. So we're going to give you a little bit of an overview about mobile crisis and what it is, what it should be, as was mentioned in the introduction there. It, in its fullest extent, has only been in existence since January 1. So we are still working out kinks in the statewide system. West Central is just one piece of the overall program as it exists. I'm really excited, as was being described in the introduction, coming from a state that my entire professional career I've known of mobile crisis because it was a state requirement in every county to have mobile crisis. So when I came to New Hampshire to hear that it was on their 10-year plan and that we could be part of implementing mobile crisis in our catchment area and our community really excited me. I know that 3 centers had it previously. They're the more populous centers, so it was Nashua, Concord, and Manchester had it for a few years now. But the structure has radically changed. They probably experienced in some ways more changes than we, moving from our old system to the current one. Bill will talk a little bit more about kind of the history and the benefit of the change, but I'm just going to hit on a few points here. We're going to try not to read off the slides in any particular fashion, but starting with the philosophy, why mobile crisis? What's the value? The idea here is to provide interventions to people when, where, and how they want them, when they're in need. I think a big thing for people in crisis is the fact that crisis doesn't happen when it's convenient, meaning it doesn't happen 9 to 5 when most practices are open and can respond to you. Plus, when you're in crisis, you usually can't be seen immediately. The benefit of the where is we will come to you. That's the inherent nature of mobile crisis. We will come to you if it's your home, if it's your school, if it's your workplace, and if you choose to. Sometimes people in crisis may not be comfortable having it in their workplace or in their home. So we might arrange a place that's more convenient and comfortable for them, but going where and when they need us. I think mobile crisis also takes an approach to view it as you can't plan crisis, but being more proactive when possible. The idea is every individual defines what's a crisis for them. A crisis doesn't have to entail I am feeling like I might harm myself. In fact, most crises aren't suicidal ideation or suicide intent. Most people that are in crisis because they have the psychosocial stressors in their life. There's a lot of discussion in recent years about the social determinants of health. And if you don't have them addressed, you can't be healthy, whether it's from physical health or mental health. So some people may be in crisis because they had an eviction notice put on their door when they got home and they don't know what to do. And especially if they get home after 5, who do you call? And crisis, exacerbate and build when you're feeling like I need somebody now and I can't wait until tomorrow to call somewhere and hope they can see me timely. So as one of the bullets references here, crises are defined by the individual, not by us as professionals. We treat them all equally relevant, and even though they might be different in how we can assist and how much effort they require from us, if you're in crisis, mobile crisis can be of an impact. One of the key things for this is for us to recognize when people are in crisis, it usually feels to them, I have few options. So sometimes the mere fact of meeting with a professional when you're in that moment and being able to help them to see that they have more options available to them than they may realize in that moment can help them instill hope. And the idea that there's resources that you can access anytime, day or night. It's 24/7. It is truly available to you 24/7. You do not have to have a mental health diagnosis. You do not have to be in care. You do not have to be a recipient of services of West Central. I view it as mobile crisis. Any one of us in this room, this Zoom meeting today, could be a recipient of this service if the circumstances presents itself. And I think that's the valuable thing. While most of the work we do is with the Medicaid population, some of the most neediest people in our communities, anybody can be a recipient of this, and at times, will be a recipient. We go into homes, we go into schools, we meet people where they're at. Real quick, kind of, what is the estimated benefit? This slide comes to us care of the state based on modeling. The idea here is with the population in New Hampshire, the number of calls per month that's anticipated to the crisis access point would be about 27, whole state, mind you, is over 2,700 calls per month with 579 deployments. Because the idea here is that a lot of crises can be resolved on the phone. They do not necessarily demand in person. So you'll hear more from Bill about those kinds of things. I can share with you the data from the state in comparison to their estimation. In just the month of January, they received 3,999 calls. So vastly more calls in just the first month than they were anticipating. Now, is that more of a curiosity? Is this something that will decrease? Is it something that will increase as the word gets out? I anticipate it'll either be consistent or it may increase. We had 515 mobile dispatches statewide. So a little bit lower, but that might mean that a lot of the issues were able to be resolved on the phone. A new introduction that isn't part of this slide is text and chats. The access point has the capacity to do texting and chatting work with people that would otherwise have had to call in. There were 48 text communications and 116 chats that were addressed. I don't know if any of those were part of the deployments, but in the end, what this slide is trying to demonstrate here is that we anticipate high volume and that because the need exists. And the idea overall, I think with the philosophy is also that a lot of times police are otherwise called. 911 activates police or EMS Under the old system, what would they do? They would typically direct people to hospital, go to the ED to be evaluated and such. We want to keep people in their community, but we also want to avoid all the negative stuff that can come with an ED visit, including cost, time, stress, things of that nature, being able to provide it in the community. And then Bill also will talk a little bit more about post-crisis follow-up kinds of issues. So from here, I'm going to turn it over to Bill, and then we'll probably tag team through some of the rest of the slides and discussions.
Well, thanks, Roger. Yeah, and I've had the pleasure to work with Roger to get this started right from the beginning. And even though it started January 1st, we've been working on it for a while now. It's going very well. I think what's important to understand is the way the system did work before. If the police were involved with someone with a mental illness, or a family member, or a school, their only option was to bring that child, and I'm saying children, or adult, to an ER. And that's just not a good place to be. It's a very sterile environment. It's uncomfortable. It's just not, especially for a 13, 14-year-old, teenager, it's not a great experience. And I think a lot of times, just based on those previous experiences in an ER, I think sometimes people are suffering in silence because they had those really bad experiences. It's not a great place to be. So again, the benefit is that we can go to people's homes. We can go to the schools. We're working more collaboratively with police departments, family members. When we go on an outreach, it's typically one master level clinician and then a crisis counselor or a peer support specialist. And the benefit to that is that, people, typically when people are in crisis, they're not alone. I mean, that can be the case for sure, but the crisis impacts the families as well. And so the good thing is that the master level clinician can kind of work with the individual that's kind of having the crisis, while the crisis counselor and the peer support specialist can work with the other family members and kind of get information and what we call collateral information that helps us to really determine kind of next steps for that individual. It's much more collaborative. The same thing with schools. I mean, typically, again, what would happen is they'd go to the ER, we'd go in, we'd see them, but it was, you didn't have all the right support for them available to really come to a good conclusion. Now, when we go right into the schools, we're working with guidance counselors, we're working with the family members, and it's pure social work, honestly. We're addressing all the needs and trying to make sure that folks have natural supports and people that they can trust. I mean, I was showing with Roger the other day that we saw a 13-year-old in a school, and in our session, he actually communicated that he felt like he had no one to talk to at school. And we brought that up to the school, and they were extremely thankful for that because they didn't know. They didn't know that that's how that child felt. So it's extremely valuable information, much more collaborative. We also had a recent situation with law enforcement where an individual who is actually an active client, but is very ill. He had not been taking his medication, and he, when he doesn't take his medication, he gets very psychotic, and he was putting signs in his house, and he was scared. I mean, and the police reached out to us because they didn't want to go into his home and physically remove him from his home to bring him to an ER. Instead, they reached out to us, and collaboratively, we were able to get that young adult to a hospital where he really needed to be. And again, we do want to try to avoid people going into the ER, but there are going to be times that that's warranted, especially based on someone's mental illness. So I can't stress enough how wonderful this is, and just the great outcomes. We're getting great feedback from the schools. They're just saying, "Oh, we're so lucky to have this. It's extremely valuable." It just feels good. I think in the month of January, we had about 18 outreaches, and about 85% of those outreaches were ER diversions. So again, we were able to come up with and develop good safety plans, not contracts, but safety plans, where the person had people that they could identify, that they could reach out to in need. We were able to do follow-up appointments with them, which is really important. I think that's the other piece of this that's so nice, is that our team can follow someone for a period of time and help them through until they get stabilized. I think when people think of mental illness, they think of people that are, there's a big spread between, someone who may be suffering with some depression, or like Roger expressed, lost their home, lost their job, and kind of dealing with a short-term crisis, versus people that need long-term care. So again, we're able to kind of follow people and get them to the next place that they kind of need to be. So I think it's just been great.
Yeah, I think the things that Bill was mentioning really reflect the desire of West Central. I think it's clearly the mission of the state is to provide mobile crisis to intervene, help people avoid higher levels of care, not just the expense, but the disruption in their lives, the impact that it has, but also to destigmatize. As I was saying earlier, you don't have to have a mental health diagnosis at all to experience a crisis and to need the help that might come with the mobile crisis team. When Bill was mentioning about the follow-up, I think the state was very cognizant of the stress and the strain on workforce in mental health in the state. And they recognized it may take time for people that do need the ongoing follow-up care to receive it through traditional mental health means, whether that's through a West Central, one of the other community mental health centers, or private practitioners. So, Bill's team has the capacity at its discretion to do follow-up for up to 30 days. They can do follow-up by phone, follow-up in person if need be, once a day for up to 30 days to transition them to more routine care in the community, which is incredibly impactful for people that after a crisis may be struggling with any kind of delay that might just be inherent into trying to get their follow-up care.
And Roger, I think it's important to also note the peer support specialist. That's a component that's new to mobile crisis. And for people that aren't familiar with that, with peer support specialists, these are individuals that have experienced mental illness. They have lived experience. They've, unfortunately had their challenges. And it's amazing how clients respond to them. I've often, as a clinician, been told, well, you're just seeing me because you're getting paid for it. Well, no, I'm not, because but when it's a peer support specialist, someone who could really relate to what they're going through, it's huge. It's huge. We actually had a situation recently where we got a call from a parent, and the child would not go to school. And this child actually has selective mutism. And one of our peer support specialists spent a good period of time, I would say probably like an hour and a half, just kind of talking with him. And he actually spoke to her. And I'll tell you, she felt pretty good after that. So that was just, again, another just great experience.
In that case, finding the right person at the right time to relate to the person in crisis in the right way, when this individual would not speak with other people. And again, the crisis in this case was the truancy, but the ability to recognize if there's something underlying why the truancy exists, how can we assist and overcome that barrier at least help them in that moment if they can resolve that. Bill, do you want to talk a little bit about what's referred to as the rapid response access point, which is run by Beacon Health?
Yeah, so I think it is important. I know all these acronyms, they get a little confusing. So the rapid response access point is actually the hub. It's being manned 24/7, 365 days a year. They are doing triage work, basically talking to the client. So that's the place where everybody calls. And actually one of the slides is going to have that information for everybody, the phone number, and everything you need. But they will try to resolve things telephonically if they can. But it's the rapid response access point that will take that initial call, do a level of triage. They will even determine at that point if an outreach is necessary. And if an outreach is necessary, they're gonna assess for safety to determine if law enforcement needs to be available. Again, it doesn't mean that law enforcement's taking the lead, because we know how that happens. I mean, the minute you have someone in uniform showing up at someone's house, I mean, it's not a good way to engage with someone that's in crisis. So we try to take the lead as much as we can. And the rapid response access point will also determine, based on the risk level, if that person just needs to go to the hospital. And sometimes that may be the case. If they're at imminent risk and they're expressing active suicidality with a plan, intent, that's not something we're going to wait on.
And I try to tell everyone that I talk to about this is call early, call often. And the reason for that is we want people to engage, starting with the phone access point early in the crisis. To Bill's, one of his last points is some people will just have to go to the hospital for their own safety. A mobile intervention is not going to help. But in a lot of crises where that might play out that way, we often discover from family members, sometimes the individual that was in crisis themselves, you know what, this has been building for a couple of days. If I would have called you 2 days ago, you might have been able to help me in a different way. So calling early is recognizing whether you're the individual in crisis, you're a family member, you're a neighbor, is calling the access point early is not a bad thing. And calling often. If someone needs to touch base with someone at 2 a.m, because that's what's going to keep them stable, that's what Beacon is there for to do. And if they determine more is needed, we're the lower half of this slide. We're the mobile crisis response team. And in references here, I just wanted to comment, in case people aren't aware, the firehouse model is the concept that we will have staff in office 24/7. Just like a true firehouse, paid firehouse model, I guess you could say, as opposed to the volunteer firehouse. People are there ready to be deployed as soon as Beacon has determined you need to go out. A later slide indicates we're basing teams. Ultimately, we're going to have 2 teams based in Claremont and in Lebanon so that we can cover our whole catchment area in more than enough time. The state's requirement is that we get to an outreach within 60 minutes of deployment. We believe with basing people in Lebanon and Claremont that we can easily meet that probably within 30 minutes because people can leave from either of those sites to help out. But again, both the master's level person that Bill referenced and the counselor or the peer specialist will be there 24/7 ready for deployment.
And then I was just going to mention that, so you have the rapid response access point where the calls are coming in, but then the team that I manage and direct is the mobile crisis team. And again, as Roger said, they're available 24 hours a day, 7 days a week. They, Beacon sends us good information about that client, where they are located, and we get our team out as quickly as possible.
So some sort of a repetitive element. The rapid, while we collaborate with the beacon access point, the phone element is on their end. So I think most of the bugs that we're working out in these first few weeks has been how beacon interfaces with the community mental health centers, because each of the 10 community mental health center covers their catchment area. We do some inter catchment area dispatches. So if for example, we're up against Merrimack County, which is covered by Riverbend Community Mental Health. If they're not available or otherwise engaged in an outreach, we might get called, and then we might deploy someone, our team, to the western part of Merrimack County to help them out. The goal is ultimately to try to be as catchment area centric so that we don't remove our resources from our community to take them elsewhere. But we're working out those nuances. They're using a system with GPS location and such so that they can know where the closest team is in order to dispatch. I think this slide kind of reflects what you said a little bit earlier, Bill, about the 2-person team, master's level clinician and a bachelor's counselor, or a peer specialist. And the peer specialist, as he said, I think is really key. Someone that can speak to the individual in crisis from shared experience, someone that has had issues with mental health issues, someone that may have experienced crises in their life multiple times, and in some cases may have experienced it under the old system when it was not as responsive as it is now. Main objectives clearly by providing or trying to provide crisis resolution, in the community, reduce psychiatric hospitalizations, including going through ERs. So this is kind of a map here of the various catchment areas. We're the orange, and the stars reflect basically where our teams are based out of existing sites that we have. So you can see we're very much more of a narrow east to west, but longer north to south. And that's one of the reasons for basing our teams in those locations. So we can travel.
Oh, you want to get questions at this point?
Yep.
Sorry.
No problem.
Okay.
I thought I was muted. Okay.
Are there questions?
Well, there are none in the, let's see if there's, oh, here it is. Yes. Heather is asking, can a family member or a friend contact the access point, receive guidance on how to help a family member without there needing to be an immediate crisis?
Without there needing to be an immediate crisis. I mean, I'm assuming you can, a family member can call on behalf of someone in their household or even a neighbor and say, I guess I'm interpreting that as possibly that a crisis is building or developing, or if we don't head it off, it will be a problem. So, again, calling early enough hopefully can avoid it from turning into a crisis. And that's probably something that I would assume that the access point would be able to handle more readily. They're going to probably deal with more generic interventions at that point. But it raises another question that maybe wasn't intended, but I'll bridge off onto that, which is, the person in crisis does not have to call. A lot of times it is family or it is a concerned neighbor that's calling and saying, and those phone contacts, allow them to recognize that a team could be deployed. Now, if we come out and the person is not willing to cooperate and interact with the team, that's certainly one thing. But if someone's risk is so significant that it might need to be an involuntary admission, the mobile crisis team can work with those individuals that have the firsthand knowledge and intervene. But our goal is to try to bridge anyone that's concerned, I think, whether that be phone with the access point or with our mobile team, to try to make sure that the right support there. And sometimes it's the other people in the person's life that can make a difference.
If I'm not overstepping my role, your comments about call early might also be perhaps what the person was requesting. I do have a second question. In regions in the US where mobile crisis units have become established, what is the experience thus far with reducing inappropriate input from police for mental health issues?
You know, when I mentioned earlier that in Pennsylvania, you know, my entire professional career, it was mandated in all 67 counties. We ran them in Delaware County and Chester County. So that's all I knew. But I also, you know, knew the positive relationship that you have and need to have with police. What we're experiencing here in our own catchment area, because this is brand new, has been I think the exhaustion from law enforcement's perspective of the things that they said we would get called out on through 911 dispatches that wasn't their bailiwick. They didn't know how to respond. They didn't know what they could do. So I think, you know, Bill can speak more to this, but just the enthusiasm of how we can work together. In my experience previously was police requesting dispatches when they had even a routine 911 that reflected these needs, as well as when we would get dispatched and we would go out and find a very unsafe environment. And, you know, when the police got called by us, they knew when we were calling that we really needed them, and vice versa. So I'll turn to Bill about what you're experiencing as we ramp this up.
Yeah, I mean, my experience with the PD right now, and again, we've had many situations where they've been involved. They've been very open and honest about, this is not our thing. We don't know what to do. And, you know, the fact that we're able to help them, I mean, they're embracing this. They don't want to be put in a situation where they're, you know, assessing someone for suicide, or, you know, they are absolutely on board. You know, again, there was a state police that were involved with the situation with the young man I described earlier. And, you know, they were the ones who reached out to us to say, hey, we don't want to physically remove this person from the home. We want to do this in a better way. And, you know, I think that speaks volumes. So I think I can absolutely say that so far, I mean, our interaction has been very positive with the PD.
And I think some things came up in the media in the last month or so in New Hampshire with respect to police shootings and the interface or relationship with mental health issues. And I think that reflects what Bill was saying, that police are aware that, you know, mental health situations can sometimes get exacerbated. Crises can get exacerbated when police officers, the authority, the badge, the gun, choose to intervene or need to intervene. That sometimes they don't have the resources, the counselor approach to bridge this so that the situation doesn't have to escalate to something that's, you know, more physically hands-on, or God forbid, tasers or weapons being drawn, kind of thing. And if you have someone that is paranoid, police showing up is not very helpful. If you have someone that's just seriously depressed, they don't necessarily see police as their solution either. And they feel like, is this criminalizing my depression and my suicidal thoughts as well? So I think we can only get better as how we, you know, develop these relationships. And I think that Bill will experience that even if we're both police and mobile crisis is deployed, arriving there, being able to say who is going to take the lead. I know from experience that the police will sometimes just stay in the background, and there's times where then you can say, we got this handled, and then they can leave, which is also very valuable for the community, especially communities that have small police forces. To have someone involved and possibly tied up in a mobile crisis situation that's not a criminal matter for an hour or two pulls law enforcement that might only have one law enforcement officer or two, pulls them out of their their route and whatnot for that period of time. So,
Roger, I think there's another question in there.
Okay.
Oh, go ahead, please. I'm sorry. Oh, there is one. There is another question. What happened prior to mobile crisis response when, for example, a student in a school threaten to harm himself or others. And how does it work now with mobile crisis? Are schools aware and know to call the rapid response access point? And do police departments know?
Absolutely. So we have done many presentations. We actually started in December before the rollout of the access point. And, we covered all the SAUs, Lebanon, Claremont, Newport. And, we expressed exactly what we're expressing today, why this is good. And again, they've certainly welcomed it. So previously what would happen is, again, they would send that person to the ER or that child. And we're talking, between 10 and 16 years old, potentially going to an ER. They would basically, call the family, say, oh, your child needs to go to the ER. And basically and also the school wouldn't even know kind of what ended up happening. But now we will go directly to the schools. We will interface again with guidance counselors, with the principal, with anybody, the family members, and we'll do the assessment there. If they need a higher level of care, then we will make that happen as well. But again, this is where mobile crisis is really hitting the point.
And people have probably heard about the ED boarding crisis. Emergency departments are becoming hospital beds for both adolescents and adults in the state because of bed shortages. So the more that mobile crisis can intervene early in a crisis, that people don't even have to go into the emergency rooms, let alone stay there. Because even in the best situation, going back to the example with the school issue, an adolescent may have to sit there for several hours. Because keep in mind, a suicidal adolescent, for example, is not the same kind of emergency for a hospital ER as people that are having heart attacks, strokes, severed limbs, things of that nature. So people can sit and wait and not receive care because they are they're lower on the triage priority. So that can exacerbate a person's crisis. That can, again, people that are doing this willingly and voluntarily going with their family there could just choose to walk away. That means no care was provided.
Well, and Roger, these kids are scared. I mean,
Yeah.
when all of a sudden they're being brought to an ER, with nurses and gowns and doctors, they're scared, and they go into a room with, little stimulus because they're potentially suicidal, and it's an awful experience. And I think, unfortunately, what's happened in the past is, again, they end up suffering in silence because they don't want to go through that again.
Right.
They're not as willing to open up and speak to their parents or speak to the school because they don't want to go to the ER. So, with mobile being able to go to their home in a comfortable situation with people around them that, love them, it's a much different experience. And it's just so much better.
And there are hospitals that have psychiatric departments that can direct resources, psychiatry, et cetera, from the psychiatric unit to the ERs. There are hospitals that don't. And those that don't, will get different interventions and support. But I think whether it's an adolescent or an adult, if you're in the ER, I think people are fearful that hospitalization is the next step. And the ability to have someone come to your home and say, that is our last, choice. We're going to try to help you here in your own home to figure out how we can navigate this together so that going to an ER or an inpatient bed is the last thing that we want to be considering. And then I think that when people have that experience personally, then they're more likely to use a service like the access point in mobile crisis in the future, because it's it doesn't have to go there.
And I think the kids feel like it's punishment, that they've done something wrong, when here they have finally expressed what's happening for them, and that's not a feeling we want kids walking away with.
So what's on the screen is the 800 number that goes to Beacon's rapid response access point. Come, I think it's July 17th of this year, the 988 equivalent of 911 will be in place. And, you know, calling that number is easier to remember than this number will be, but 988 will not get you anywhere today. But New Hampshire has created newhampshire988.com this is for the chat, correct? So they can do chat online. I think we're yet to see the chat and text. We know that younger generations love to communicate through chat and text. So we've yet to see, I think, will this really take off with the access point? But regardless of how they communicate with Beacon, if Beacon determines that the crisis has not been resolved, mobile crisis will be deployed. Other questions?
So on the New Hampshire state level, what is the proportion of the mobile service responses that are associated with individuals under age 18?
It's a good question. I don't know. Do we have that data yet?
What I could say is the numbers of, so, and actually I was listening to the news the other day. I mean, nationally, and again, this goes back to what we've all dealt with for the past couple of years, the pandemic. In particular, children were affected. They're saying that it's a mental health crisis for kids right now because of the isolation that they have endured, lack of, you know, peer interaction. You know, I would go out on a limb and certainly say that we have had more outreaches for kids than we have for adults, for sure.
And my experience has been that is probably about roughly 50-50. Our peak times were, and we're anticipating and gearing up for that for some additional staff support at those times, was kind of the noon to 8 p.m., late in the afternoon for many reasons, but for adolescents in particular, and early hours at home. I mean, family crises, again, it can go to an individual that doesn't have a diagnosable mental health issue, but family crises that boil over. Kids are home, parents are home. They just cannot navigate how they're relating to one another. Words are exchanged, threats are made. I think Bill has probably already seen that where, you know, 911 gets called over silly things, and, you know, we're going to get pulled into those things to help de-escalate the interpersonal family issues. I don't think that there's any reason, you know, to discourage any of that going through the access point, or if a mobile outreach is going to resolve those issues. But, you know, I think with adults, it's much more classically diagnosable mental health issues, depression that's worsening, thought disorders that, you know, they're getting paranoid, they can't function, they can't care for themselves. With kids, it's a combination of stressors, conflict, as well as, you know, classically diagnosable mental health issues.
All right, another question is, does the access point assist families with completing paperwork, Medicaid applications, or other sorts of paperwork needed to help their family member?
Do you want to answer that, Roger, or do you?
I was going to say, I mean, I think we can assist bridging them getting access to benefits to some degree. If that's likely to occur, I assume, Bill, you're going to just connect them with ours or whatever community mental health center that they're in, connect them with ongoing case management services who are much more experienced with connecting people to things like the Medicaid and navigating through those applications. But I think any resource, you know, classic resource that can be helpful. I mean, again, if the crisis issue is at 2 in the morning and someone is saying, I'm going to be homeless by the end of the week, you know, we might say, let's talk through what we can do here. We'll connect you with an appointment with a housing office or with, you know, a homeless shelter. I mean, the crisis team will help them navigate through whatever system that, helps alleviate the crisis at the moment and tries to transition them to ongoing supports.
Absolutely. When we do a follow-up appointment, if we learn that that's one of the challenges the family is incurring, we deal with homelessness and many other, substance obviously is a big topic. We will certainly help a family with Medicaid.
Okay. One other question. The fact that a need exists doesn't always result in new services or new funding being established. What were the drivers for establishing mobile crisis services?
I don't know that I quite heard that.
So that there are many unmet needs. The fact that the need exists doesn't necessarily always result in services being reformatted or new services being established. So what were the drivers for establishing the mobile crisis services?
I think the drivers, unfortunately, one of the bigger drivers was just ED boarding and the lack of beds, because you had your traditional community mental health resources and you had inpatient and you had less supports that were somewhere in the middle. And, it's unfortunate that New Hampshire was kind of slow relative to other states to embrace it. It was in the 10-year plan, which I think was developed in 2018.
Yep.
So, I appreciate the fact that they embraced it and said, this is something that we can and should be doing. It won't be the panacea for ED boarding. It will alleviate a lot of stress points, I think. I think Bill has shared with me amazing stories about the successes and the amazing stories about his teams coming back from outreaches and just being so pleased about what they were able to do, especially knowing prior to this existing where the process would have gone, where this person might have ended up. And the more that we can do that intervention early might mean they don't even necessarily need ongoing, psychotherapy and psychiatry, but knowing that, you might have saved me from having an ER visit and maybe even being hospitalized, and knowing that I can follow up with you guys as well. So, as I think this shows its benefit and we see less pressure on the hospitalization process, we see, reduction of stress on other points in the system. Hopefully the state, will be able to take a step back and look for other ways that we can innovate what we're doing, whether it requires money or not, to say, how can we tweak the system so that we're really expanding the continuum of the care that community mental health can provide.
Seems to be, I'm sorry.
I was just going to mention that I think one of the other challenges, Roger, early on, because they've been talking about mobile for a period of time. And I think one of the challenges that people, I don't think it's, one of the challenges was that the regional aspect of New Hampshire, while they had three existing teams, Manchester, Nashua, and Concord, I think a lot of people were unclear whether it would work in the more regional places of New Hampshire, but it's working. It's working.
Good.
There is one more question right now, and that is, how is mobile crisis funded by the state, and is it funded fully?
Okay, excellent question. It is funded through state general funds is the ultimate funding source, but for individuals that have Medicaid, when that's identified, Beacon would identify that at the initial call. I mean, we're not collecting copays out in the community. We're not navigating and negotiating information about their payer. But if they are a Medicaid recipient, those individuals, the first charge would be created by billing the Medicaid system, with state general dollars being there to support the overall firehouse model. We've yet to really see, will it fully support? I think when the state sat down with their actuaries and looked at what they thought it would take for each region, I was actually very pleased with what they thought it would cost based on the staffing pattern they thought that West Central would need for our population and such. I was very concerned if they would, be shortchanging the view about what would be needed in the firehouse model. So I was pleased with that. But we're really only, a month and a half in. So 6 months, a year in, we'll really know, will that be supporting it? We've had very generous donations to mobile crisis from individuals and some foundations and such. So much so that just a few weeks ago, we were able to use some of that donation money to purchase 2 SUVs for the 2 teams, because that was not part of any kind of base funding from the state. So it was through donations of individuals in the community that made it possible for us to have the SUVs, so that people had a predictable, reliable, winter-proof vehicle to get to individuals. They didn't have to rely on their own vehicles to do such. But we're going to continue to monitor what it's going to take. I think as we really get a sense of what outreach is and whether we need more staff. I mean, we have a shift model. We have a 7 to 3, 3 to 11, 11 to 7 kind of model with one person that straddles, that does a noon to 8, just given the history of that being a more vital time. But if you only have a 1-2 person team in Claremont and a 1-2 person team in Lebanon, if there's more than 2 crises going on at a time, that third crisis will not have a mobile outreach resource. And if we see that there's a higher demand, we may have to go back to the state and say, listen, to serve everybody based on the data, we need more funding.
So a question for you. What can we as the Eastman community do to help support your efforts? I mean, one of the things that occurs to me is clearly in our resource guide, we should be putting information and maybe there are posters and other things that we could use. Is there anything else you would suggest that we as a community could do?
I think just communicate the call early, call often, and let them know, let everyone know. You don't have to be in the mental health system. You don't even have to believe you have a diagnosis. If you're experiencing a crisis in your life, telling your neighbors, telling everyone to say, this service is not only there, but use it. Don't feel like you have to wait until things really get so bad that it's like, okay, I have to do it. Because, if you call us, even if it's 2 a.m, we will come out. But if we come out because you waited to the very end, we might have, the only thing we might be able to do is just facilitate you getting to a hospital. We'd rather have better outcomes. So letting people know that call early, call often mantra is okay. I mean, I shared it with the state, and I did a joint presentation with some state people back in December. And I said, are you okay with me saying this statewide? And they said, absolutely. They liked that it was just a simple way to say, don't second guess what it means to be in crisis. If you feel you're in crisis, you're in crisis. And not to say, well, but it's not the same as somebody else. It doesn't have to be. Because again, the whole idea with almost 4,000 calls in the month of January, I mean, that's only what 1/8 of them turned into mobile outreaches. That's wonderful that so many of those things could be resolved by phone. But when it needed a mobile outreach, those resources are there too.
Are there any other questions from anyone, Paul? I don't see any. Okay. Then I definitely want to thank both of you. This is really very, very interesting and a very exciting presentation. And we really appreciate the fact that you were willing to take the time to share it with us. And,
I appreciate you having us.
Yes.
Yeah, and so again, if people have other questions or if they want to let us know something relative to evaluation, just get in touch with us, Eastman Cares at eastmannh.org, and we'll be sure to get back to you. Okay.
Thank you so much.
We will see you all next time. Thank you again.
Bye.
Bye.